Good evening, everyone, and welcome to the third of 3 webinars for the OAT demonstration project. My name is Sarah Rabinovich, as you might remember from last week, and I wanted to thank you guys for taking the time this evening to join us on this webinar. We will be going over the programs of care, or POCs, for upper and lower extremity injuries tonight. If you have not yet watched webinars 1 and 2, please do so as soon as possible. And if you have any questions, please save them for the end, and I'll do my best to answer them. It is vitally important to the success of our data collection and ultimately the demonstration project that the cases are selected appropriately and the discharge reports are completed accurately and submitted in a timely fashion. The purpose of this evening's webinar is to review the inclusion and exclusion criteria for each POC as well as the proper method for completing the forms associated with each POC. The upper extremity POC has been selected by the OATA for the demonstration project because as athletic therapists, the treatment and treatment modalities used for this POC are well within the AT scope of practice, and it includes many public domain acts. This POC also includes conditions that are generally major areas of treatment for ATs. The following injuries can be classified as an upper extremity case: minor rotator cuff tears, rotator cuff tendonitis, lateral epicondylitis, impingement syndrome and bursitis of the shoulder, and carpal tunnel syndrome. In order for the patients to be included as a case for the demonstration project, there are several criteria that need to be met. Treatments must be initiated within 12 weeks of the initial injury or onset of pain. The patient must be diagnosed with one of the earlier mentioned conditions by a physician, athletic therapist, or other medical practitioner, and the patient must be able to safely participate in the treatment approaches described in the POC. They must not present with any evidence of red flags. A red flag for patients to be excluded from the project would include any clear indicator for immediate surgical intervention, hospitalization, acute inflammatory arthropathy, infection or fracture at injury site, neoplasm, significant unexplained weight loss, advanced neurological deficit, and major tears or shoulder dislocations. If a patient exhibits red flags and is not able to be a candidate for the demonstration project, you may still choose to follow the outlined POC. But in those cases, you would not complete and submit a discharge report, as it could skew the results of the project and weaken the outcome. Yellow flags are psychological risk factors such as avoidance of activity, preference for passive treatments, mood issues, or social withdrawal. The combination of several yellow factors may add up to one red flag. Several yellow flags may add up to one red flag, and that would be under the discretion of each therapist. The tools that will be used to assess the outcome measure will be the Quick Dash and Quick Dash work module. These are an 11-question and 4-question tool, respectively. These 2 quick questionnaires are to be completed upon assessment and discharge of the patient. The scores from these questionnaires will be input into the discharge report. Copies of the Quick Dash and work modules will be made available on the OATA website. Now let's go over the recommended treatments or interventions that will be included in the upper extremity POC. First are the shoulder injuries: rotator cuff tear or tendonitis, impingement, and acute bursitis. There are 2 recommended treatments for these injuries, and they are exercise prescription, a mix of supervised and home exercise programs to focus on stretching and strengthening the shoulder, and manual care, which will include soft tissue mobilizations and massage for increased mobility and pain management. Secondly, we have lateral epicondylitis injuries. There are 4 recommended treatments for this injury, and they are exercise prescription, to include a progressive stretching and strengthening program with task-specific exercises to reduce pain and increase grip strength. This should be the core component of any patient within this POC. Ultrasound. This is recommended for a short to medium-term pain relief as a potential intervention supporting an active exercise program, manipulation and/or mobilization, and acupuncture. This may be used as a non-pharmacological pain management strategy. I must remind you that acupuncture constitutes part of a controlled act and therefore may be performed only by ATs who have been trained to perform the procedure safely and effectively, and only those ATs who are also a member of a healthcare profession who is authorized to perform this act. Lastly, we have carpal tunnel syndrome. There are 3 recommended treatments for this injury, and they are night splinting, a splint worn only at nighttime to reduce unwanted pressure on the median nerve, ultrasound, and manual and manipulations and/or mobilizations. These last 2 treatments are not intended as standalone treatments, but rather as non-pharmacological pain management strategies. Now let's go through the treatments not recommended for use within this POC. First, for the shoulder injuries, they are acupuncture, electromagnetic therapy, electrotherapy, laser, needle aspiration, and shockwave therapy. Second, for the lateral epicondylitis, they are ionization, pulsed electromagnetic field, laser, and Rebox. Thirdly, for carpal tunnel, they are acupuncture, low-level laser, braces, magnets, and full-time splinting. As stated last week, if a manual technique or the use of a particular modality is in your scope of practice and you feel confident to administer it, and you also feel that the administration of that technique or modality will be in the best interest of your patient, then you may include it in your treatment. Whenever possible, however, please try to stick to the recommended interventions listed. As we end off the upper extremity injury portion of the webinar, I will remind you that the submission of the discharge reports is absolutely crucial to the success of the demonstration project. One more time, for the project to have any measure of success and usefulness, a discharge report for each patient included in the demonstration project must be completed fully and appropriately and submitted. This can be done using the fillable forms on the OATA website and can be submitted electronically. Please note that the forms online at the moment are in the process of being updated. These updates, along with the postings for long-form descriptions and algorithms for POCs, will be posted before the commencement of the data collection. Now we are going to move on to the lower extremity programs of care. Some of the information will be repeated from our presentation of the upper extremity POC, but some aspects are specific to the lower extremity, so I think it's important to review. As with the upper extremity POC, the lower extremity POC was chosen for the demonstration project because it is well within the scope of practice for ATs and it includes the performance of public domain acts. The included lower extremity injuries are also generally major areas of treatment for ATs. The following injuries can be classified as a lower extremity case: acute ankle sprain, patellofemoral pain syndrome, and patellar tendinitis. In order for a patient to be included as a case for the demonstration project, there are several criteria that need to be met. Treatment must be initiated within 3 weeks or 21 days of an ankle injury, or within 4 weeks or 28 days of an anterior knee injury. The patient must be diagnosed with one of the earlier mentioned conditions by a physician, athletic therapist, or other medical practitioner. They must have a mechanism that is consistent with an acute onset, and the patient must be able to safely participate in their treatment approaches described in the POC. They must not present with any evidence of red flags. A red flag for patients to be excluded from this project would include fracture or gross instability, any clear indicator for immediate surgical intervention, hospitalization, acute inflammatory arthropathy, that's my second time at it, infection or fracture at the injury site, neoplasm, significant unexplained weight loss, advancing neurological deficit, major tears, either ligamentous, complete muscular rupture, or meniscal tears. As mentioned earlier, if a patient exhibits red flags and is not a candidate for the demonstration project, you may still choose to follow the outlined POC, but in those cases, you would not complete and submit the discharge report, as it could skew the results of the project and weaken the outcomes. Yellow flags are as mentioned as above, and they are at the discretion of the therapist as to whether or not you believe they will add up to a red flag.